So Srinivas, welcome. Dr. Srinivas is a very dear colleague who works in our hospital in Hyderabad, has a special interest in TAVI. Dr. Nagendra, I understand your 2 cases of pop-out, but today, what do you think with the new valves and the good planning, what do you think is the pop-out rate with these valves? And what are your determinants and commandments to prevent this complication?
So I think pop-outs are mainly happening initially because our technique was like we are learning this, but now only pop-outs are happening in patients where there is no calcium. So generally in these cases we are going with the self-expanding valve, not with the balloon expanding valve if there is no calcium. But still, if you are like an extreme cases where surgery is high risk and there is no calcium and you have to do it, there is always a chance of pop-out with balloon self-expanding valves. Chances of pop-out with balloon expandable valves are less because we are not taking them for non-calcific valves. I think with the newer modifications in the Medtronic valves and with the curve and slightly more radial strength, chances of pop-out are less. So Hydra valve initial one had a slightly less radial strength. That's why this pop-out happened. So I think out of our more than 300 cases, we have only 3 pop-outs, and the 2 were done in the initial 1 or 2 years, and now in last maybe I think 3 years, we have just 1 pop-out. So I think technique, understanding the case, and the new modification, the valve has changed this to significant manner.
Even in today's era where we have repositionable valve, if patient has a significant LVOT hypertrophy and has a large chunk of calcium below, I think those are, and as you said, less calcium in the aortic valve location, those are subsets where we should still be careful not to have pop-outs. I think in your experience, Dr. Chandra, whether taking appropriate size or slightly oversized is better to prevent pop-out, or what are your advice in such scenarios where there is likelihood of pop-out?
Yeah. In fact, in the patients where we have this septal hypertrophy, so there are 2-3 steps we can take in these. If the hypertrophy is too big, if the bulge is too big, then we can do a septal ablation first and then do a TAVR in these patients. The second is if the septal ablation, the septal bulge is not too big, then in those cases you can actually position the valve slightly higher. Actually, otherwise if it is too low, then what happens, it just squeezes out and then it can just pop out. So we try and do that good positioning. The third is if there is a calcification. If the calcification is not too much, then we don't pre-dilate and then try to do with the implantation straight away without doing any pre-dilatation in these cases. So these are the steps you can do to prevent pop-out in these situations.
Dr. Khanna, can you hear me now?
Yes, Dr. Sanjay, we can see and hear you and see your presentation also. Yeah, now it's in the presentation mode.